Dear friends of Dermoscopy, welcome to this podcast, which will be the first among a series of podcasts focusing on the use of dermoscopy in general dermatology. In a previous podcast, we already analyzed the basic principles of inflammoscopy, meaning the parameters to be evaluated when applying dermoscopy in inflammatory skin diseases. In this podcast, we will focus mainly on papulosquamous dermatosis. Under this term, we traditionally include several entities with similar clinical presentations, but among them, the commonest diseases are psoriasis, dermatitis, Lichen, Planus, and Pityriasis rosea. Certainly, in their typical form, these diseases can be easily diagnosed based on the morphology and the distribution of the skin lesions. However, not uncommonly in everyday practice, a skin eruption is not typical enough to lead us to a straightforward diagnosis. In such cases, the differential diagnosis usually includes some or all of the diseases mentioned above, and histopathology is often required to solve the diagnostic dilemma. Particularly in this context, dermoscopy has been shown to significantly improve the clinical diagnosis, achieving a sensitivity of 88% and a specificity of 84.9%. However, although these numbers are important, we should always keep in mind that dermoscopy is only one part of the clinical examination and should always be combined with all the other methods we use in order to reach the goal of diagnosis. This is probably the first image coming in mind when speaking about dermoscopy of inflammatory skin conditions. These are the red dots, or dotted vessels, of psoriasis described more than a decade ago. Today, we know that red dots can be found in every single psoriatic plaque, so that if we see any other morphology of vessels, the diagnosis of psoriasis should be excluded. However, we also know that red dots do not represent a specific finding for psoriasis, since they are present in almost all of the entities included in its differential diagnosis. Instead, the distribution of vessels, which is characteristically regular, symmetric all over the lesion surface, represents the most specific dermoscopic finding of psoriasis. Furthermore, the color of scales, which is always white, is also a useful clue. Of note, the visibility of vessels might be often impeded by the presence of thick superficial scales, like in this case. However, the red dots are clearly evident in the uncovered parts of the lesion. In heavily hyperkeratotic psoriatic lesions, removal of the scales with an alcoholic solution will reveal their underlying, regularly distributed dotted vessels. The dermoscopic pattern of psoriasis remains the same also in lesions located on specific sites, with obvious variations in the amount of scales. For example, scalp lesions are often highly hyperkeratotic, and the vessels can only be detected in the uncovered parts of the lesion. Psoriatic lesions on the face again display regularly distributed dotted vessels, this time along with the expectedly enlarged facial follicular openings. While lesions located on the folds or on the glans penis also exhibit red dots in a symmetric distribution, which are usually clearly visible because of the lack of hyperkeratosis. This is an example of palmar pustular psoriasis, where dermoscopy reveals the white scales, the red dots, but also the characteristic pustules. Certainly, among all papulosquamous skin diseases, dermatitis is the most frequent. Under dermoscopy, dermatitis also displays red dots. However, in contrast to psoriasis, the vessels are not symmetrically arranged all over the lesion. Often they form clusters. Other times they are present in one part of the lesion and absent from other parts, forming an overall patchy arrangement. Most importantly, the color of scales in dermatitis is typically yellow or white plus yellow, reasonably because of the underlying spongiosis and crust formation. Of note, this finding is valid not only in cases of acute dermatitis, but also in chronic forms, and this sign is very useful for the discrimination of the disease from psoriasis, which typically shows white scales. The same dermoscopic pattern characterizes all dermatitis subtypes, including nummular eczema, seborrheic dermatitis, contact dermatitis, and atopic dermatitis. Again, there is a variation in the amount of scales, but not in their color, which is always yellow or white plus yellow. And this is a case of hyperkeratotic hand eczema, dermoscopy revealing dotted vessels combined with yellow scales, in contrast to the cases of palmar psoriasis we saw before, which displayed white scales. The presence of peripheral white scales is the dermoscopic hallmark of Pityriasis rosea. Certainly, this is also a well-known clinical sign, but as it is reasonable, its visualization is significantly enhanced by dermoscopy. Please note that also Pityriasis rosea exhibits dotted vessels, further highlighting that they do not represent a specific finding. Lichen planus is maybe the most easy to diagnose inflammatory skin disease with dermoscopy. This is because dermoscopy reveals the absolutely specific Wickham striae, which is present in every single lesion of Lichen planus. Please remember that before dermoscopy, Wickham striae was thought to be present only in mucosal lesions, while today we know that it can be seen in all skin papules of the disease, but we just have to apply our dermatoscope. At the end of this module, we will see some characteristic clinical examples which highlight the usefulness of dermoscopy in the realm of inflammatory skin diseases. These are two similar papulosquamous eruptions developing on the trunk of young individuals. Their clinical discrimination is virtually impossible. Application of the dermatoscope immediately allows an accurate diagnosis. The lesion on the left displays regularly distributed dotted vessels, absolutely compatible with the diagnosis of psoriasis. Instead, the red dots of the lesion on the right are not symmetrically arranged, and yellow scales are clearly present. This pattern is highly suggestive of dermatitis. These two adult women present with erythematosquamous macules and papules on the trunk. This eruption is compatible with Pityriasis rosea, but also with psoriasis, dermatitis, or Lichen planus. Under dermoscopy, the lesion on the left shows the characteristic psoriatic pattern of regularly distributed red dots and white scales. In contrast, the lesion on the right displays a peripheral colorate of scales strongly suggestive of Pityriasis rosea. Finally, this hyperkeratotic palmoplantar eruption is clinically suggestive of psoriasis. However, application of dermoscopy reveals the characteristic Wickham striae, allowing the correct diagnosis of Lichen planus, which would be very difficult on clinical grounds only.